Welcome everyone. Welcome to our September NILE webinar. We're waiting for some more folks to join us before we get started. Have a couple people still trickling in, so I'm just going to give a couple more minutes for that. You are welcome to put your name and organization in the chat so we can do quick intros, but thank you for joining us, and we'll get started in a couple more minutes. Welcome again. My name is Latoya Scarrett. I'm the program director at Immunize Nevada. I have my colleague on, Erin, who will be assisting and facilitating. We have two amazing presenters for today. So thank you again, everyone, for joining us. I'm just going to give another minute or so, and then we're going to get started today, go over a couple of housekeeping items first before we jump into today's webinar. All right, we're gonna go ahead and get started. Erin, you can go to the next slide. Thank you. So again, thank you for joining today's NILE webinar. Just a couple of housekeeping items. If you happen to have any sort of connection issues, just jump back in. We will be here. The Q&A chat will remain open. If there are any questions that may come up during the presentation today, feel free to drop them in there. We have 15 minutes towards the end of the webinar to make sure to get to your questions. So you don't have to wait till the end. You can, as they come up, just put them in the chat or in the Q&A box, and we will get to those. I know that a lot of people on are interested in receiving CEU credit for today's webinar. Please stay on until the end of our webinar. Once the webinar closes out, the CEU survey will launch, and that will allow us to provide you with CEU credit for today's webinar. So you just want to make sure that you're staying on towards the end and you are completing the survey that automatically launches once the webinar closes. Next slide. This is just a disclaimer. Immunize Nevada's NILE webinars are made possible by the generosity of speakers who donate their time and expertise to benefit the coalition. The expectation and goal is for community partners to gain knowledge on immunization, infectious disease-related topics through a non-branded, unbiased presentation. The opinions expressed of those of today's presenters do not necessarily reflect those shared by Immunize Nevada or its partners. Next slide. So without further ado, I am so grateful and thankful. We have two amazing presenters joining us today. We have Ms. Hannah Nine and Ashley Lack with the American Cancer Society. Our presentation today is on HPV vaccine. Why, how, now? Cancer prevention made easy. Thank you both for joining us. Ms. Hannah Nine is a senior program manager on the Mountain West HPV project with the American Cancer Society. She is a Colorado native, born and raised in Woodland Park, Colorado. Hannah studied biology at Western State College of Colorado and has worked for the American Cancer Society since 2007. She's passionate about cancer prevention and early detection, having lost her grandmother to breast cancer at a young age. Welcome, Hannah. Ashley has joined the American Cancer Society in 2009. Ashley's work focused on key areas including prevention, early detection, access to care, and health equity. As HPV Program Manager, Ashley's work is solely now focused on increasing HPV vaccinations in rural and frontier communities within the Mountain West. Ashley received her Bachelor's of Arts in Communication from DePaul University and her Master of Health Administration from Ohio University. Ashley holds a basic certification of quality and safety from the Institute for Healthcare Improvement and Certified Professional in Healthcare Quality Certificate. Some of Ashley's work has been nationally published, including a project around increasing colorectal cancer screening in an uninsured Hispanic community and quality improvement initiatives that led to significant increase in adolescent HPV vaccines within a large academic health institution. Today's programming, attendees, you will gain knowledge on HPV infection and disease through HPV vaccination recommendations, including the many reasons to start the series at age 9, and lastly, review ways the American Cancer Society has partnered with health systems to implement innovative interventions to improve HPV vaccination coverage in Nevada. So excited to jump into this topic. Thank you and welcome again, Hannah and Ashley. I'm going to turn it over to the both of you so we can get started. And if there are any questions that come up, please, attendees, drop it in the chat, drop it in the Q&A. Ashley and Hannah, you can take it from here.
Well, perfect. Thank you so much, Latoya, for that grateful and gracious introduction. So welcome everyone, and thank you again for joining today's webinar, HPV Vaccine, Why, How, Now, Cancer Prevention Made Easy. Like Latoya said, I'm Ashley Locke. I'm an HPV Program Manager here at the American Cancer Society and work with Hannah on the Mountain West HPV Vaccination Project. I'll let Hannah introduce herself.
Hi all, good afternoon or good morning, depending on where you're joining from. Hannah Nine, Senior HPV Program Manager with the Mountain West HPV Project.
Perfect. So we are so excited to partner with Immunize Nevada on today's webinar. Want to thank you all for taking time out of your busy day to join us. We do want to make today's webinar very interactive, so we will be using Slido to do so. I'm going to ask everyone to either pull out their phone and scan the QR code that's on that slide, or go to your computer browser and put in slido.com, and then you can put in #NILE to answer questions along the way. So go ahead and go to the next slide. I do want to share that all answers will remain anonymous on Slido, so don't be afraid to answer honestly. We're going to go ahead and give it a try. So we'd love to hear where everyone is joining from today. Looks like we're slowly getting in answers. Reno, Las Vegas, Nevada, Carson City, Salt Lake City, perfect. So we got someone joining from North Carolina. Give it a couple more seconds, and then we can go to the next slide. Perfect. Well, thank you all for participating in our initial poll. It's so wonderful to see so many of you joining from a variety of different places within Nevada as well as outside of Nevada. So before we get started today, I do want to disclose that American Cancer Society does receive funding from the CDC, Merck, and Lida Health Philanthropies to support our HPV programming. Next slide. And this is just a quick agenda with some of those learning objectives for today's educational session. I won't review them in depth, but we will be going through the basics of HPV. We'll be talking about vaccination guidelines, touching on provider recommendations, and talking through strategies and interventions for increasing HPV vaccinations in your role and community. So I'm going to now turn over to Hannah to talk through the prevalence and impact of HPV.
Thanks, Ashley. So I want to take a moment to just dive into what is HPV. So HPV stands for the human papillomavirus. HPV is a very common virus, and about 80% of people become infected with HPV in their lifetime. And it typically happens during the teen and young adult years, prior to age 21. In fact, new research shows 50% of new HPV infections occur in 15 to 24-year-olds. However, each HPV typically has no symptoms, so most people don't even know they have it. There are over 150 different strands of the virus, but only 15 of them can cause precancerous and cancerous symptoms. 90% of HPV infections go away spontaneously within 2 years and don't go on to cause cancer. HPV has become a true public health concern. HPV infection causes a lot more than just physical impacts and harm. It has significant financial, social, and emotional impacts as well. HPV causes approximately 37,300 cases of cancer in men and women each year in the US, based on the most recent data. We'll talk a little bit more about the breakdown on cancer type on the next slide. More than 1.3 million women each year are diagnosed with low to high-grade cervical dysplasia following a routine Pap test. Dysplasia, in its simplest terms, are abnormal cells on the cervix. These women require additional treatment to prevent cancer. Among men and women, there are over 355,000 cases of genital warts each year. However, data models show that 90% of HPV-related cancers and precancerous symptoms can be prevented with HPV vaccination. I want to share a little bit more about cervical dysplasia and its impact on those with the cervix. Individuals with a cervix who have advanced precancers need to have the abnormal cells cut out to prevent cancer. This is done with a cervical conization or LEEP procedure. These procedures help prevent cancer in 9 out of 10 cases, but can sometimes lead to pregnancy complications down the road. The cost of these procedures in the care of premature infants is expensive to patients and to our overall healthcare system. Vaccination can prevent these precancers, so fewer will need to undergo these procedures. There are a lot of misconceptions about HPV vaccination. However, it's a tool to prevent cervical cancer without impacting fertility or pregnancy outcomes. For those with a cervix who aren't vaccinated or regularly screened, cervical cancer can develop, and cancer treatment for cervical cancer usually involves either removing or radiating the uterus, which leaves them unable to have children later in life. So now that we've talked a little bit about precancers, I want to review a breakdown of the 6 types of cancer that are attributed to the HPV virus. There's an estimated 37,300 HPV attributable cancers per year in the US. An HPV attributable cancer is a cancer likely caused by HPV. HPV causes nearly all cervical cancers and most cancers of the vagina, vulva, penis, anus, and oropharynx. A little more than half of HPV attributable cancers in women are cervical cancers, while in men, the majority are oropharyngeal cancers. In fact, oropharyngeal cancer is now the most common HPV cancer, surpassing cervical cancer. While many people understand the connection between HPV and cervical cancer, fewer people are aware that HPV is causing a rising number of oropharyngeal cancers each year. These HPV-related cancers occur in the tonsils and the base of the tongue. They're hard to detect clinically and often present at stage 3 or 4. When we look at trends in oropharyngeal cancer incidence, we see that incidence rates have increased among men in all age groups. White men are the most likely to develop oropharyngeal cancers, followed by Black men and American Indian Alaskan Native men. Additionally, age matters. As you can see from this graph, most cases largely occur after the age of 50, evidenced by the top 2 trend lines. Incidence rates also have increased among women 55 and older, but clearly at much lower rates than those of men. Note the bottom 2 trend lines show how few cases there are during the years after adolescence, between the ages of 20 and 49. This is a good reminder that it takes years for HPV to present as cancer. You can see here the 6 different types of cancer that HPV causes. It's important to focus on prevention because only one of those 6 types has an FDA-approved screening modality. We cannot screen for most HPV cancers. Screening for cancer is important, but HPV vaccination is cancer prevention. So at this time, we're going to ask you to go ahead and use that Slido again. What surprises you most about HPV infection on population health? We have the incidence. Throat cancers, yes, it's a startling number and going up. The higher number of older adults. That there aren't more screening modalities available, yes. Rising rates of oral cancer. That more kids are not vaccinated against it, yes. That's why we're here today. How it can take years to show, yes. Well, thank you all. Really appreciate you participating through this. We love using the Slido tool and being able to interact with all of you. So we're going to go ahead and move on. So we know that according to US Census data, there are approximately 21,220,214 10 to 14-year-olds in the United States. A special report released in 2022 showed that between 2019 and 2021, only about 37% of US adolescents were fully vaccinated by their 13th birthday against HPV. We have a cancer prevention vaccine that when given on time can help prevent 6 types of cancer. And the American Cancer Society is on a mission to protect kids today from cancers tomorrow with the HPV vaccine. The vaccine is over 90% effective and it's readily available. We have a new suite of age 9 and science behind age 9, vaccinating at age 9. And this is just one of the quotes that came out of there. If HPV vaccination rates rose to 80%, 53,000 more cervical cancer cases would be prevented over the lifetime of those aged under 12 years. So I want to talk a little bit about the HPV vaccination guidelines. In 2020, the American Cancer Society updated their HPV vaccination guidelines, stressing that vaccination should occur between ages 9 and 12 after examining the evidence base. HPV vaccination is recommended for boys and girls between the ages of 9 and 12. The American Cancer Society and the American Academy of Pediatrics encourages providers to start recommending HPV vaccination at age 9. This is consistent with recommendations from ACIP and CDC as well. Kids who don't get vaccinated on time can still get vaccinated into their teens and early 20s. Vaccination works best at the recommended age, but late vaccination will still give some protection. We'll be discussing vaccination in people over age 26 a bit later in this presentation. So why 9? The HPV Vaccination Roundtable did a lovely 9 reasons why we start at age 9, and I just thought I'd highlight a couple of them here. Number 1, it offers more time for completion of the series by the age of 13. It results in a strong immune response to the HPV vaccine, increases the likelihood of vaccination prior to first HPV exposure, decreases questions about sexual activity by parents and guardians. It decreases requests for only vaccines that are required for school, decreases the number of administered shots per visit, increases vaccinations and therefore the number of cancers prevented. It's been shown by several systems to increase HPV vaccination rates and has been shown to be highly acceptable to systems, providers, and parents. So we've been building this lovely evidence base on why vaccinating at age 9 should happen. And there are a lovely just collection of resources, videos, articles, all kinds of publications. And I would encourage you all to check this out. All the links throughout this you can click on them. So we would love for you to check out that lovely suite of those age 9 resources. So it's that time again. What do you consider the most important benefit for vaccinating at age 9? Lots of people typing, but it looks like yes, vaccinating prior to exposure, kind of taking the lead there. Higher immunological response, yes. Followed by decreased sex talk, more time for completing the series, and decreased talk on school-required vaccines. So thank you again for using Slido and actively participating. We appreciate it. So this is just an additional highlight of those age 9 articles. Encourage you again to check that out. And then just to touch on why the American Cancer Society does not recommend HPV vaccination after the age of 26. The ACS does not endorse the 2019 Advisory Committee on Immunization Practice recommendation for shared clinical decision-making for some adults aged 27 through 45 who are not adequately vaccinated because of low effectiveness and low cancer prevention potential of vaccination in this age group. No guidance for shared clinical decision-making, which creates a burden on patients and clinicians. A lack of sufficient guidance on the selection of individuals who might benefit, and evidence shows minimal benefit. It prevents less than 1% of cancers, precancers, and warts. So I'm going to go ahead and turn it over to Ashley now to talk a little bit through efficacy.
Perfect. Thanks, Hannah. So like Hannah shared, in the next actual 2 sections, we're going to talk in depth about the safety and the effectiveness around the HPV vaccine, and we hope this information will help you to feel more confident in recommending the HPV vaccine series to adolescents and their parents. If you want to go to the next slide. For many years, we had some really strong evidence to show the efficacy of the HPV vaccine in its reduction of cervical precancers and cancers in England, Sweden, Finland, and Australia. However, we now have the evidence that the human papillomavirus vaccine is extremely powerful at reducing cervical cancer in the United States. So each year, the American Cancer Society releases new scientific data in our cancer vaccine figures. So new evidence was announced at the beginning of this year showing that there's a 65% reduction in cervical cancer rates in women ages 20 to 24 from 2012 through 2019 in the wake of the introduction of the HPV vaccine. Although the incident rates were already declining because of routine cervical cancer screening, the HPV vaccine has really accelerated this progress. You want to go to the next slide. So this particular slide talks a little bit more in depth about that study, but what it shows you is that among women in the ages of 20 to 24 cohort, cervical cancer incident rates declined by a total of 33% from 2005 to 2012. However, it more than doubled to 65% from 2012 through 2019. And when we look at rates across race and ethnicity, the trend lines are moving in the right direction. And like I said, this is really exciting news because most of our evidence showing the vaccine's effectiveness has come from countries outside of the US. If you want to go to the next slide. So let's talk a little bit more about the vaccine's effectiveness in England. So in 2021, Falcaro and colleagues published a study that highlighted the benefits of HPV vaccination for cancer prevention. So in England, United Kingdom, their HPV vaccination program was introduced in September of 2008, promoting the bivalent HPV vaccine. So the authors examined the impact of the program on precancerous lesions of the cervix and cervical cancer, and they found a substantial reduction in precancerous lesions and cervical cancers in young women following implementation of the HPV vaccination program. This was particularly true for those who were vaccinated at ages 12 to 13. Resulting in hundreds of fewer cases of cervical cancer and more than 17,000 fewer precancerous lesions of the cervix. The authors concluded that the HPV immunization program has successfully almost eliminated cervical cancer in women born since September 1st, 1995. You want to go to the next slide. In addition to evidence showing a decrease in cervical cancer, there's really some solid research on the vaccine preventing HPV infections of the head and neck, so oropharyngeal region. In fact, a US-based study looked at more than 2,600 males and females between the ages of 18 and 33, found that those that had received the HPV vaccine had actually an 88% lower rate of oral HPV infection compared to those individuals without the vaccine. So this particular study is one of the reasons that the FDA actually approved in 2020, adding the indication of head and neck cancer prevention to the vaccine's indications. And we know now is the prevention of HPV oral infection is very promising for the potential of the vaccine to protect against oropharyngeal cancers in the future. And in fact, there are more studies being done now to show the efficacy of the HPV vaccine and its protection against oropharyngeal cancer. You want to go to the next slide. So despite an overwhelming amount of evidence to show the vaccine's effectiveness in preventing cancers and precancers, we now have strong evidence to show a strong immune response and higher titers when adolescents initiate the HPV vaccine series at age 9 and 10 and complete the series by the age 13. And as always, it's our best protection from HPV cancers, and it's important to vaccinate before exposure to the virus ever takes place. Additionally, there are more than 12 years worth of ongoing studies that show that the HPV vaccine is long lasting and that there's going to be no booster needed in the future. You want to go to the next slide. So not only is the HPV vaccine effective, but we know it's safe. So prior to the COVID-19 vaccine coming to market, the HPV vaccine was the most studied vaccine in the US. So think about that. The HPV vaccine has been studied more than Tdap and Meninge, yet most parents aren't afraid or resist those vaccines, and providers regularly recommend both of them. You want to go to the next slide. However, if there are any remaining doubts about the safety of the HPV vaccine, this slide should provide you some assurance. There have been 109 clinical studies, 2.5 million people, and in 6 countries, and none of those have shown serious side effects reported from the HPV vaccine. And the vaccine continues to be studied today. Next slide. Additionally, you should feel confident that the US has very robust monitoring systems, which we'll review in depth on the next slide. And there's more than 15 years worth of safety data. As well, there have been 135 million doses of the HPV vaccine distributed in the US and 500 million worldwide. And that number actually continues to increase every day with more adolescents being vaccinated. Next slide. And like I had shared, this particular slide reviews the systems we have in place in the US, which includes spontaneous reports, active surveillance, and special epidemiological studies to review the safety of all vaccinations, including the HPV vaccine series. Next slide. So how can we achieve our goal of 80% by 2030 HPV vaccination? Well, what we know is that a strong, high quality recommendation for the HPV vaccination matters, whether it's coming from a provider, a nurse, an MA, a public health professional, a pharmacist, a dental provider, and so on. Everyone needs to be on the same page when it comes to recommending the HPV vaccination series. Next slide. Just know that what you say matters and how you say it matters a lot. So the best predictor of vaccination uptake for both hesitant and non-hesitant parents was how the vaccine was recommended and conversation was started. Next slide. What we do know is there's a big disconnect between parents and providers when it comes to the value and importance of the HPV vaccine. So in fact, research conducted by Dr. Mary Healy and colleagues in Texas looked at the value parents place on adolescent vaccines. When parents were asked how much value they place on each of the vaccines, you can see from this slide in particular that they ranked all vaccines similarly between a 9 and 10. That includes Tdap, pertussis, and HPV vaccine. However, when providers were then asked to estimate how much value parents place on the same vaccines, as you can see, they guessed correctly for vaccines protecting against meningitis, hepatitis, pertussis. However, the estimates that clinicians gave for how much value parents place on the yearly flu vaccine and particularly HPV vaccine was much lower. These clinicians underestimated the value parents place on HPV vaccine, which has led to lower quality recommendations for the HPV vaccine, especially at those younger age groups. And in fact, studies are now showing that clinicians delay talking about the vaccine because of perceived notion that parents will outright refuse the vaccine in its series. Next slide. So let's talk a little bit more about provider recommendation and its effect on HPV vaccination uptake. So in 2014, researchers conducted a national online survey of about 1,500 parents with children between the ages of 11 to 17, where they looked at the quality of the recommendation given for the HPV vaccine and how likely they were to get their child vaccinated. So parents reported whether providers strongly endorsed HPV vaccine like they did other vaccines, encourage same-day vaccination, and discuss the vaccines as cancer prevention. So using an index of those quality indicators, the researchers then categorized the parents as having received no, low, or high quality recommendation for the HPV vaccine. The results showed almost half, so about 48% of the parents reported that they received no provider recommendation for HPV vaccine, while 16% received a low quality recommendation and only 36 received a high quality recommendation. When you compared the parents who received no recommendation to those who received a high quality recommendation, the study showed they were 9 times more likely to initiate the HPV vaccine series and over 3 times more likely to follow through with completing the vaccine series. Parents who received a low quality recommendation were more modestly associated with initiating the series, but not following through with completing the series. Additionally, parents who received a high quality recommendation less often reported HPV vaccine refusal or delay. Next slide. So what has HPV vaccination recommendations looked like? Well, for many years, the classic technique was the sandwich of packaging all 3 adolescent vaccines given during the 11 to 12-year-old visit. It sounded something like this. Selena needs 3 vaccines today to protect against meningitis, HPV cancers, and whooping cough. She will get those at the end of the visit. This idea of the sandwich approach started back in 1996 when well-child visits typically did not occur beyond kindergarten. So the CDC, the AAP, and the American Academy of Family Physicians got together and helped to establish a routine visit for 11 to 12-year-olds to provide an opportunity to catch up on those routine vaccines. This especially became important for hepatitis, and then even more important as adolescents came to market like meningococcal, Tdap, and of course the HPV vaccine. However, over the last decade, research has shown it has become more clear that the bundling approach has failed, especially for the HPV vaccine. And when a vaccine is delayed at the 11 to 12-year-old visit, it's almost always the HPV vaccine. Next slide. So with the emphasis now on age 9, the time has come to dismantle the sandwich. In fact, now the idea of an adolescent platform of vaccines timed to 1 single visit, so 11 to 12 years of age, is less necessary. Almost 80% of 6 to 11-year-olds regularly schedule yearly well-child visits, which makes it more important to not only educate, but recommend and initiate the HPV vaccination series. So what might this look like now? So Juan is 9 years old, which means he's due for his first dose of the HPV vaccine, which protects against 6 types of cancer. We will give it to him at the end of this appointment. A retrospective study showed that adolescents who started the HPV vaccine series at age 9 or 10 were 22 times more likely to complete the 2-dose series by age 15 than those who initiated the series at age 11 or 12. Next slide. So we've discussed recommendations in depth, and we know making a high quality recommendation helps to not only increase HPV initiation, but also follow through for completion. However, I do want to acknowledge that vaccine hesitancy is a real thing and something we all face every day. So vaccine hesitancy is not a new issue, but it has been escalated in scope and scale. In fact, the World Health Organization has named vaccine hesitancy one of the top 10 global health threats and has been heightened because of the COVID-19 pandemic and amplified by social media platforms. What this slide shows you is that vaccine acceptance is truly a spectrum. On the left-hand side, you see that there are individuals who are fully accepting of all vaccines. Whereas on the right-hand side, you see what we call our anti-vaxxers, which studies have shown there's about less than 5% of anti-vaxxers across the population. However, somewhere in the middle, so the light green, yellow, and light orange, emerges hesitancy or reluctance or refusal to vaccinate despite availability and access to vaccines. So in simple terms, vaccine hesitancy means that some may refuse some vaccines, they may delay some vaccines, and they may accept some vaccines. Go to the next slide. So I do want to take a minute and share where do you personally land on that spectrum of vaccine hesitancy. And I do want to remind everyone that all answers in Slido will remain anonymous. And I did see in the chat, someone had a question about how to access Slido. If you pull out your phone and you scan the QR code and put in hashtag NILE, you can participate, or you can also go to a browser and put in slido.com and then put in hashtag NILE. So it looks like we're starting to get some answers. And as you guys continue to share, I'll share that I personally probably would categorize myself as accept some, refuse some, and delay some. So my primary care provider doesn't always provide a recommendation to get that yearly flu vaccine or the COVID booster, and I personally haven't sought it out myself. However, when I was pregnant with my son and my OB-GYN made the recommendation to get the whooping cough booster, I happily complied. So it looks like majority of you accept all vaccines, which is wonderful, but we do have some that accept some, delay some, and refuse some. So I appreciate you guys participating in this poll, and we can go to the next slide. I do want to go back to the scale and share that recommendations matter, and you can see just from my own experience. So for those who do experience vaccine hesitancy, it's important to work to build confidence in vaccines and know that vaccine hesitancy threatens to reverse any progress that we have made over the past years in tackling vaccine preventable diseases, which we're seeing in the rise of HPV related oropharyngeal cancers. Next slide. So this map here actually shows the rate of vaccine hesitancy across the US. And you can see that the orange and red pockets mean that those areas have high levels of vaccine hesitancy. And as you can see, there are definite pockets across every state, including Nevada. Next slide. So in the next section, we are going to talk through some of the most common refusals around the HPV vaccine. But before we do, Hannah and I would love to hear what vaccines you see and hear from parents in your community surrounding the HPV vaccine. So please feel free to share. Okay, it looks like we're starting to get some answers in. So someone shared experimental, safety, not part of the school requirements, government is watching my family, it's not needed, it's harmful, don't believe in vaccines, don't need them, don't believe in them. Perfect. Too new of a vaccine. So I appreciate you guys for sharing, and you can continue to share. But we're going to talk through some of those hesitancies and how you can kind of overcome them with 1 to 2 sentences. But we could really do a whole training just on communication strategies when it comes to the HPV vaccine. However, a lot of research has been done into how we should talk about HPV vaccine. So first and foremost, the most important message that I want you to remember and take away from this training today is that HPV vaccination is cancer prevention. This is not about sex. It's not about STIs. We need to normalize the vaccine. We want parents in the community to know that the human papillomavirus is just a virus. When the HPV vaccine first came to market, we shot ourselves in the foot talking about it as protecting against a sexually transmitted infection. It's nothing to be ashamed about. 80% of the population will encounter HPV during their lifetime, but most infections go away on their own. However, some do lead to those precancerous symptoms and cancers. However, we don't know who's going to get it and who's it's going to affect. So we need to protect everyone. When you talk about the vaccine to patients and parents, share with them why HPV vaccination is important to you. If you vaccinated your child, share that with them. Tell them, because that's important. Be encouraging of all recommended vaccines for every child, not just the minimum required for school. And be prepared to take action. We want every recommendation and conversation to end with an adolescent receiving that HPV vaccine. So if you aren't a vaccinator, then help the parent make an appointment or seek out a place to get the vaccine. Next slide. So what happens if a parent does show concern or hesitancy? Like I had shared, there's research that is shown to ask what their main concern is and to try to overcome the hesitancy by sharing 1 to 2 sentences that talk through facts and make them feel more confident in their choice. So don't go down the rabbit hole and data dump on the parents. And we're going to kind of quickly review some of those biggest hesitancies around the HPV vaccine. So the number one thing we hear, and I know a few of you added this, is the HPV vaccine is not safe. Well, we've talked in depth about the safety, but feel confident knowing that over 500 million doses of the HPV vaccine have been distributed worldwide, with over 135 million doses in the US continue to show that vaccine is is safe. And a one-liner you can share to overcome hesitancy would be, this vaccine is one of the most studied medications in the market. The HPV vaccine is safe, just like other vaccines given at this age. Next slide. The second would be the HPV vaccine is just for girls. Well, the fact is HPV vaccine is recommended for all adolescents, since both men and women can get HPV-related cancers. So a one-liner you could use, HPV infections don't care about gender. The virus can cause cancer and many other diseases. Next slide. Myth number 3, the vaccine has harmful ingredients. The fact is, HPV vaccines contain ingredients that have been proven to be safe. The HPV vaccine does contain aluminum, which boosts the body's immune response to the vaccine, and the amount in vaccines is smaller than what we encounter in food and cooking utensils daily. Next slide. Myth number 4, you must have sexual intercourse to get HPV. The fact is, HPV is spread by intimate skin-to-skin contact. People who have not had intercourse can become infected with the virus. So something to overcome that, this really isn't about sex. The HPV vaccine is about preventing cancer. Next slide. Another one. The HPV vaccine causes teens and preteens to become sexually active. The fact is there's no research that shows a correlation between HPV vaccine and increased sexual activity. And so once again, you could share, this really isn't about sex. The HPV vaccine is about preventing cancer. Next slide. Myth number 6, HPV vaccine can lead to infertility. The fact is, there have been studies with over 200,000 women who have found no association between HPV vaccine and premature ovarian failure. In fact, as Hannah had shared before, HPV diseases and cancer can cause and can harm fertility, so that the HPV vaccine actually helps protect your fertility for the future. Next slide. And HPV vaccine and school requirements. So there are several states that do require the HPV vaccine for school entry. However, there aren't many, and Nevada is not one of them. This doesn't mean it's less important than other vaccines. So what you could say to overcome that is school requirements don't always keep up with medical science. The HPV vaccine is an important vaccine that can prevent many cancers. Next slide. And if you have more questions about why the HPV vaccine isn't school mandated, just know that most school mandates are based on politics and economic considerations, not medical ones. All recommended vaccines, including the HPV vaccine, are just as important as the vaccines required for school. Next slide. So why does this all matter? We've just come out of a global pandemic, which has severely affected vaccine uptake. And if we don't take action now, research models show that it will take almost a decade for HPV vaccinations to recover. Next slide. And in fact, industry data has shown 8.4 million doses missed from the start of the pandemic to earlier this year. We are facing a gigantic gap, which equates to about 12% of publicly insured adolescents and 15% for commercially insured adolescents missing their HPV vaccination doses. Next slide. And to share even more bad news, for the first time in 10 years, HPV vaccination initiation did not increase among adolescents aged 13 to 17. And this is per the National Immunization Survey, so NIST is for short, 2022 survey. Initiation actually fell among adolescents insured by Medicaid and remained lowest among the insured. So 2 out of the 4 groups that can situate the Vaccines for Children program, highlighting the continued need for outreach among adolescents eligible for the VFC program. Additionally, the 2022 survey showed that HPV vaccination coverage by age 14 years among adolescents born in 2008 continued to lag behind earlier birth cohorts and varied by socioeconomic factors and access to healthcare compared with coverage among earlier birth cohorts as well. Next slide. So additionally, not only are we recovering from the pandemic, but many of our states, including Nevada, face geographic disparities as well. This slide reviews the National Immunization Survey for teens based on geography. So looking specifically at that first dose of the HPV vaccine, we see that adolescents living in rural areas have always had lower vaccination coverage compared to adolescents living in those urban areas. However, while there has been a difference in vaccine coverage, this slide demonstrates that vaccination coverage in rural areas has increased over time, but because the increase in coverage is slightly at the same rate as the increase in coverage for teens living in those urban areas, difference remains the same between the two groups. Next slide. So can we start to recover? Well, what we do know, there is no one single intervention that will bring us to 100% uptake, but we believe that by combining multiple evidence-based strategies with earlier introduction, we can make significant progress towards eliminating HPV-related cancers in the US and beyond. We know there's room at the table for everyone, and we all play a role in cancer prevention. So in these subsequent slides, we'll review actions for health systems, for state organizations, and health plans, and share some best practices. So for health system partners, the National HPV Vaccination Roundtable put together an action guide that highlights 5 steps you can take to help increase HPV vaccinations in your system or clinic. First, you can establish an HPV vaccination team. You can educate your leadership on the importance of the HPV vaccine. You can create a cancer prevention culture within your clinic or system. You can reduce missed opportunities, and you can evaluate, sustain, and celebrate success. Next slide. I do want to highlight a system out of Seattle, Washington that followed the action steps laid out and worked to increase on-time HPV vaccinations amongst their 9 to 13-year-old population. They conducted a formal quality improvement project between 2008 and 2012, and the interventions they implemented included immunization posters, they did EMR supports, provider and staff training, strong provider recommendations, some educational resources, and peer-to-peer champion coaching. And they had a lot of wins from their project, but what they found was HPV initiation rates at ages 9 to 10 increased at least 30 percentage points in clinics that were implementing multi-pronged interventions. Next slide. We've also laid out action steps for individuals working in state and government organizations. And these can include communication strategies. You can look at your IAS capabilities, and you can explore partnerships to increase HPV vaccinations. Next slide. And in fact, in Washington State, once again, they used the actions provided and started a campaign to activate HPV vaccination at age 9. The interventions that they implemented included their state immunization registry forecasting age 9, the ability to track HPV vaccination coverage rates at 9 to 10 years of age. They wrote Dear Doctor letters encouraging HPV vaccination at 9, and they created a robust grouping of communication materials for providers and community partners to use. Next slide. And lastly, we have put together some actions for health plan partners, including activation and resources shared with health systems and providers and network, and opportunities to activate amongst members and their parents. Next slide. So best practice I want to share is that in 2022, a study from the American Cancer Society actually looked at 28 health plans who are engaged in a 12-month vaccination learning collaborative, which included quality improvement targets, implementation of multi-pronged interventions, and participation in quarterly best practice sharing calls. What the results showed is that 25 out of the 28 systems, so about 89% of the participating plans, reported including a focus on ages 9 to 10. Additionally, health plan interventions could be maximized to target initiation at ages 9 and 10 by using provider and patient reminders, targeted provider education, and dose-specific provider pay-for-performance and patient incentive programs. However, we are continuing research to show and explore the impact health plans' roles can have on HPV vaccination uptake and the types of evidence-based interventions that are best fit to the role of a health plan. Next slide. We are going to end today's session by quickly sharing some resources to support your work increasing HPV vaccinations. There are numerous patient and provider-facing resources available to you from the American Cancer Society, the CDC, and the HPV Roundtable. Next slide. This slide highlights actually the American Cancer Society resources, which are parent-facing and can be found by visiting cancer.org/HPV. I do want to note most of these flyers are available in multiple languages, and they are also available to be co-branded. If you're interested in doing so, please feel free to reach out to myself or Hannah to talk further about that. Next slide will highlight some of the CDC's resources available for both clinicians and parents. They have a CDC HPV hub. They have clinical resources. They have a parent-facing website as well. Next slide. The National HPV Vaccination Roundtable also has a host of starting at age 9 resources that include toolboxes for providers and health systems, coalitions, and parents and advocates. These include social media messaging, newsletter content, as well as links to other, helpful resources. Next slide. As well, the National HPV Vaccination Roundtable collects materials from a variety of different resources, which you can access through their resource library. Next slide. Lastly, I do want to share that the American Cancer Society has a brand new on-demand HPV provider series available through December. And you can find more information and register for the series by scanning the QR code on this slide. Next slide. Additionally, we do have on-demand HPV education for oral health professionals, which you can learn more about scanning the QR code, also listed on this slide. Next slide. I know I've shared a lot of information today, but we did want to end with hearing what is one action you're going to take as a result of this training today. Sounds like, so share information with staff, educate with more confidence, change the discussion. That's great. Ordering materials for outreach in the community, spreading the information, sharing Red Book with our providers, begin adjusting recommendations to start at age 9, share material and resources with providers, continue to advocate for our PCPs to recommend the HPV vaccine, education on the importance of the vaccine, sharing more facts with more confidence. Those are all really great actions that you're going to take as a part of this training. So thank you for sharing. If you want to go to the next slide. So I do want to just share some key takeaways. It doesn't matter your role. We should all be cancer prevention advocates. Remember, your recommendation matters. Always be advocating for the HPV vaccine at all visits, especially in those adolescents 9 to 13 years of age. Remember that most parents are getting the HPV vaccine. However, some just need some more information, and know that 70% of parents who initially decline the HPV vaccine eventually say yes. And just remember that the HPV vaccine is cancer prevention. And one last slide. I do want to end with this quote, which is from that age 9 collection. So in contrast to vaccination coverage, the burden of HPV-related mortality in the US far surpasses the mortality from tetanus, diphtheria, pertussis, and meningococcal disease combined. So please use your influence and your power to become a cancer prevention advocate today. Thank you all.
Thank you. Thank you so much, Hannah and Ashley, for that amazing presentation. So at this time, if you have any questions, please put it in the chat, use the Q&A box. We're happy to get those over. I will give a couple more minutes. We have about 7 more minutes left in our webinar. If you have any questions on the information shared today from Hannah and Ashley, I'll wait for that. I know some people are requesting your contact info in the chat, Hannah and Ashley. A reminder, if anyone is on and they need CEU credits, please stay on until the end of the webinar. Once it closes, you'll be able to do the survey to receive CEU credits for today. There is a question that I'm going to read out. So Sherry's asking if she read it correctly that the vaccine is 90% effective.
That is correct, yes.
Let me see what other questions we have coming in.
And we're happy to provide a copy of the slides, Latoya, if that's okay. I want to make sure that's okay.
Absolutely.
You can provide a PDF copy.
Yeah, I have another question from Yvonne. What are some of the ways by which people are exposed to HPV if not sexually?
So it'd be skin to skin contact, intimate skin to skin contact. So, and just to, I think then, so did I read that right? Sherry's question was, is the vaccine 90% effective? It's actually 90% effective at preventing precancers and cancers in the future. Sorry.
You have another question. Do you have any advice or guidance for breakthrough cases like revaccinating?
That's a great question. From our experience, you would not revaccinate. So, if the child got their first vaccine, let's say at 9 or 10, you would just continue the way that the guidance says. So 2 doses. But if they had received all their doses of the HPV vaccine and then got the virus in the future, you wouldn't vaccinate any more than you had already done. I hope that makes sense.
Okay, and why is there now a stronger recommendation to start at age 9?
I think that's a great question, and I would encourage you to check out that collection of the science behind age 9. There's a lot of emerging science that shows why vaccinating at age 9 is more effective, more robust immunological response. There are quite a few things in there that support the science behind 9, and I would just encourage you to take a look at that. Ashley, I don't know if you have anything you want to add.
Yeah, just like Hannah said, that there's just a lot of research to show the evidence to support age 9. I personally vaccinated my daughter at age 9 because once I saw the research behind the higher titers, for me, that was, my main reason why. I knew by protecting her early, she would have the best protection for when she does become exposed to the virus. So, but like Hannah shared, there's tons of information in that collection, and hopefully you'll have time to review it.
Elizabeth has a question. Are you working with states all over the country to get this vaccination required for admission to schools?
I would say, Elizabeth, no, we aren't necessarily working with different groups to get it required. The states that do have it required have very high uptake of the HPV vaccine. So I think in states where they're, upwards of 80 or 90% of initiation of that series, they can see some really great progress by requiring it. But in states where they're much lower, that would be an uphill battle, I would encourage you to look at the study that was done in Texas. They had, for a short time, required the HPV vaccine, and it turned into, it didn't work out for them. Let's just put it that way. So I would encourage you to read some of the case studies.
Okay. And then I guess we have another final question here, and this is a follow-up to the recommendation for age 9. Does the ACIP plan to update its routine recommendation for when to begin the HPV series from 11 years to 9 years?
That is a great question, and we are hopeful that perhaps with this new NIS teen data being released and showing the first time in 10 years that HPV initiation did not increase, that it would perhaps encourage ACIP recommendations to more strongly recommend starting at age 9, but it has always been included in their recommendation that the vaccine can start at age 9.
And there's another question in regards to age. KJ said the Cancer Society doesn't recommend for ages 26 to 45. And as an employee health nurse, I get requests for this vaccine. So do you have any research of how low the effectiveness is to share?
We can definitely put some sources in the chat if that would be helpful. It's just I think the conversation around that age group, so the 27 to 45, you know, it's a tough decision making if the adult has, you know, an established primary care provider and can have an honest conversation around, you know, what their sexual activity looks like and all of that, then they can make a better decision about whether or not the vaccine would be appropriate for that individual. It's just you know, the research doesn't really support that, and there's just not a ton of guidance around that clinical decision making. So
Thank you. And I think that ends our question and our webinar for today. Thank you everyone for taking the time to join us. We had a really amazing turnout. Thank you, Ashley. Thank you, Hannah, for sharing all the resources that you have shared. This webinar will be posted on our website, as well with any resources that Hannah and Ashley have shared today, and also their slides. So I just want to thank everyone again for joining us. Thank you. And if you are interested in receiving CEU credits, that will launch at the end of the webinar. So I hope to see everyone on again for our October NILE webinar. You are on our listserv, so you will definitely get the information and the link for that. But again, thank you everyone. Have a pleasant day. See you until next time. Bye, Ashley. Bye, Hannah.
Bye, thank you.
bye.